We are going to get started because, it's 9. Wow, I thought we were even running late. Welcome to the 2024 Hot Issues in Health Conference. I'm Sarah Schmidt. I'm the president and CEO of the Colorado Health Institute, and I'm really excited to see all of you today. I'm learning how to use things too. We will have live Spanish interpretation for this conference provided by Community Language Cooperative. There are headphones in the back, and if anyone who is in the room currently would like to have interpretation, if you could, just in the back corner are my communications colleagues, and they can get you set up. Okay. So as we are preparing and gathering and coming together as a community, we want to honor and acknowledge that both the Colorado Health Institute as well as the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Apache, Arapaho, Cheyenne, Comanche, Kiowa, Lakota, Pueblo, Shoshone, and Ute nations. We honor and celebrate these nations as well as the 48 contemporary tribal nations that are historically connected to Colorado. And we all commit to advancing policies and programs that address past and current inequities and improve health. We are in such a wonderful and beautiful space, and we have Dean Kathy Bradley and the Colorado School of Public Health to thank for that. We are very honored to be co-presenting this conference with the School of Public Health, and I am very pleased to invite the Dean to come up and welcome us. In addition to her role as Dean, Kathy Bradley holds the Paul A. Bunn Jr. Endowed Chair in Cancer Research and is Deputy Director of the University of Colorado Cancer Center. Kathy, welcome.
Thank you, Sarah. Good morning, everyone. It's great to see you all here today and to be part of the annual Hot Issues in Health Conference. And this is such an important gathering of our partners throughout the state and to really think about these issues because public health is such an important part of our lives. And I think in many ways it's going to be discussed at the dinner table like it's never been discussed before. So we have a real opportunity, and I thank Colorado Health Institute for choosing us to host this conference and to be part of the discussion. So thank you very much. So I see many attendees here that are part of the Colorado School of Public Health, our faculty, our staff, our students, our alums. Some of our board members are here today, and certainly all of our partners. So thank you for attending as well. And I hope everyone takes time today to connect with each other and to rekindle relationships and build stronger communities, because that is really what it's all about. The Hot Issues in Health Conference serves as a platform for connecting decision makers and thought leaders to ensure that healthcare and public health remains a cornerstone of well-being for all Coloradans. And public health cannot be something that we turn to in times of crisis. It really has to be part of the conversation much earlier on. It's a science that's proactive, driven, that shapes our everyday lives and works to improve health and well-being for all Coloradans, whether it is to address a crisis like a pandemic or our day-to-day activities around promoting housing, security, improving mental health for the population. And as the dean of the only school of public health in the Rocky Mountain region, it is such a pleasure to be part of this discussion. And I want to acknowledge and celebrate the fact that our school has played such a central role in shaping the well-being of Colorado. Our school was founded in 2008, And since then, we have been advancing public health research, education, and practice to address the most pressing public health needs. We've trained much of the workforce across the Rocky Mountain region. And in just 16 years, we've become one of the leading schools of public health, one of the highest ranking in the nation in a very, very short time. And I'd like to just highlight a couple of achievements in the last year. We earned a stellar reaccreditation review for the next 7 years. We launched a new PhD program in climate and health. We published its first comprehensive resource bank on gun violence in partnership with the CDPHE. We expanded our global health efforts through the Trofino Center for Human Development in Guatemala, and we are involved in over 35 countries and recently hired a new leader for our Global Health Center, Elizabeth Brickley, who will be joining us from the London School. We have rising new scholarship funds to ensure public health education is within reach to more students. And we've expanded our outreach in historically underrepresented populations in rural Colorado. And we've launched our 5-year strategic plan to ensure that the work to be done in the next 5 years is ready to go. And we're ready to hit the ground running, whatever challenges that we're about to face. So we've been extraordinarily busy. Looking ahead, our leadership team, we're certainly aware of the headwinds that we face. And we're going to take that on because that's part of being in public health. That's the deal. And political landscapes change. They change all the time, but we are a profession that is steadfast and that endures. And over the course of our careers, we're going to see a lot of political changes. This is just going to be another one. And it's not a time to shrink, but to take center stage and to be part of this discussion. Because as I said earlier on, public health is going to be discussed in ways in which it's never been discussed. Things that this audience takes for granted, they're going to come to the dinner table. And we're going to start talking about vaccines and that we thought was settled science. We're going to talk about all kinds of things. This is an opportunity for us to seize, an opportunity for us to start to tell our stories and to tell them in a more compelling way, because we're going to be challenged and challenged in ways that we haven't been before and on platforms that our predecessors could not even imagine. This is our chance. This is our chance. And so we need to seize that opportunity. Other things, doubling down on our science. Public health is a science. It seems like common sense sometimes, but it's backed by pretty hard evidence and science. We need to keep doubling down on that. Train our students like we've never trained them before. Really challenge them on rigorous methods. Prepare them to communicate so that they're able to go out and face these challenges. Keep in mind that health and well-being is not a political ideology. It is something we strive for each and every individual. And let's not make it become part of an ideology. Evidence-based, centered in science, proven in practice. That's what we do. Keep steering that conversation back. Tell our success stories. And the other component is broadening the tent of public health, making it relatable to everyone because it matters to everyone. We're such a crucial part of society and crucial part of society's success, and the world is getting healthier, and we embrace this joint vision of a healthier tomorrow. And the discussion we're going to have today is all part of that thinking. And I'm glad that we're having this conference before that our new administration takes over, gives us all a chance to get into that mindset. What are we going to do? We're certainly not going to shrink, and we're not going to panic. We're going to go forward and embrace our science. So with that, I want to get this conference kicked off. So thank you all again for being here.
Okay. Thank you, Dean Bradley. Thank you again for hosting. Thank you for your personal and professional leadership on these important issues and for the work that you and all of your colleagues out here are doing to build the next generation of a public health workforce. We need everybody. All right, we're filling in. We do have seats up front, so if you need some space, come on up. You're welcome. You're welcome up front here. Speaking of welcome, we have over 200 people who are joining us online from really across the country, mostly Colorado, but we do have some folks from across the country, so want to welcome our virtual audience, and they will be participating with us through the chat and the Q&A, so if you're virtual right now, keep your chat handy. Also want to acknowledge that I am not Jeff Mosier, our board chair, and that is what is in your program right now. Jeff had an early morning conflict, but he will be here mid-morning. I do want to acknowledge and thank our board of trustees who have been such a tremendous support for the organization. We have one board member here in the room with us, Leanne Jolan. Is she here yet? There she is. Hi, Leanne. Thank you. Thanks for being part of our board. And we have a few board members joining us virtually because they are all across Colorado. So welcome to our board. Okay, we could not do this conference if we did not have sponsors and organizations that believe in the conversations that we're going to have today and are willing to provide financial support to bring us all together. And we are very honored and grateful to have our gold sponsor, Compass One Healthcare, with us today to really serve, again, as our primary sponsor, and very grateful that Corey Neff, the Senior Vice President for Sales, is here with us, and she is going to talk for just a minute to let us all know who you are and what you do. So come on up. And it's just clicking this one to move yourself forward.
Thank you, Sarah. Thank you, everyone in the room. We are honestly just so honored to be invited to this forum today. In advance, want to thank you for the work. I love what happens next matters more than anyone, matters more than ever. And I think those of you in the room are really going to shape the trajectory that we're on for the next several years, as has already been discussed. Compass One Healthcare is really a family of companies. We provide outsourced services that are not core competencies to the health systems themselves. When we think about ourselves, we're able to provide integration at a speed to market that is sometimes not accessible within the budget or within the means of the individual IDNs or the systems. We look to ourselves to be a trusted partner and take the scale of our community, which spans the entire continental United States. We have 80,000 associates. We're in several thousand locations. And our objective is to bring the best to the forefront of the problems and the opportunities that your health systems or your health providers face. We're very successful in our marketplace. We're the #1 market leader. We're probably most proud of our retention rates. And once we join in partnership, our biggest accolade is our ability to grow and flourish for very long periods of time. Just met a woman yesterday whose first job was here in Colorado. She moved her family from Mexico. She didn't know even how to speak English. She joined our team as an EVS house cleaner, and she's now the director of our department 17 years later, and she's providing for her family. And these are the types of opportunities that we're, again, most proud of. So as you think about the future of healthcare, and you think about the pivotal moment that you're facing, and some of the nuanced changes that need to go into generating profitable outcomes, driving workforce engagement to new levels, optimizing revenue streams in the face of the constrictions from new regulatories, think about Compass One Healthcare as an opportunity for you to dial up the care for your caregivers and your communities. Think about retail in the environments that we serve as an opportunity for communities to congregate and nourish each other and take a moment of reprieve. Think about the story I've just shared with you with Leena, who came from Mexico and 17 years later is the provider for a first-generation immigrant family in the United States. We can bring analytics to the forefront so that you know the decisions that we are making are in the best interest of your institution, and ultimately access you to a supply chain that allows us to continue to provide no matter the circumstances. So thank you very much. We're privileged to be here in attendance with you today. The work that you do is absolutely imperative, and thank you for allowing us this sponsorship opportunity. Thanks so much.
Thank you, Corey and Matt, and once again, thank you to Compass One. The interpreters from Community Language Cooperative are here, and so if you would like interpretation, please just head into the back and they'll get you all set up. Also, if you're standing in the back, you can sit up front. There are chairs up here. You are most welcome. All right, so in addition to Compass One, we've had many sponsors, and again, we are always grateful to them and for them. Grateful to our silver sponsor, the Colorado Health Foundation. I think Emily was going to be here. I'm not sure if she's in the room here. I can't really tell. We are grateful to our bronze sponsor, Rocky Mountain Health Plans, a United Healthcare company. I know we have a few folks from Rocky who were going to be joining us today. Just want to give them a special shout out and their colleagues at United Healthcare with the challenges and the struggles that they've had this week. Also want to thank Colorado Access, our meal sponsor, and great to see some familiar faces from Colorado Access. And we also are grateful for the support of Colorado Community Health Alliance and Connect for Health Colorado. Our sponsors are great. They keep our ticket prices low, so thank you for that. And they also help with accessibility, with interpretation, for example. Most importantly, they provide scholarships. And we are so excited to have 13 scholarship recipients with us here today. Folks that have come from across Colorado, representing community-based organizations, rural communities, organizations led by people of color, students. I'm very excited to have our scholarship recipients with us as well too. So, okay, before we kick off, let's give a round of applause for our sponsors and our scholarship participants. All right. Okay. I'm almost ready to be unchained from the podium, but I have to do one more thing first. I have to make sure I've gotten everything. Yes, okay. All right. I need to hear from all of you. I need to hear who you are and sort of what you've been up to and how often you've been at hot issues. And so we are going to, we're going to try something here. So while you're waiting for me to get this set up, everybody who is on the virtual audience, open up a new browser. And if you're in the room, open your phone. It's probably open, but open your phone and go ahead and pull yourself away from your email and go ahead and open up a browser. All right, we're trying it. We're trying Mentee. So go ahead, www.mentee.com. Type in the number 8928-9283. All right. Okay. Everybody got it? Got it? No? It's okay. It's all right. All right. Okay, I'm clicking forward. Oh, you can still get the code. It's still on the top. All right, everybody. How many hot issues and health conferences have you attended? Now, there could be up to 400 people responding in this Mentee, so we have 92 right now. I need to see a few more. Let's keep going. Okay, 127. See, there's that ticker on the side, and it tells you how many, so I'm going to be checking. One more minute here. Let's keep going. Oh, all these little hearts. That's sweet. Okay. All right. It's slowing. The ticker's slowing here. That's pretty good. Wow. So this is amazing. So if you're in the room, raise your hand if this is your first Hot Issues in Health conference. Yeah. Welcome, everybody. Excellent, which means that there's lots of others. Who in this room remembers when we used to be in Colorado Springs? Hands high. Oh my gosh. Okay, that's great. Sorry, I love. Well, if it's your first or you're like, I don't know, 14th, Whitney Connor, there you are. You're welcome. You are welcome to this conference. We're going to have fun. We're going to talk about some serious things, but we're all here together, and that's the best part of this conference. So excited to get into it and get going. and see if I can actually do this. So hang on here. Oh, there we go. There we go. Okay. All right. And now I'm just supposed to hit this little button over here. Yes. Did it work? Yes. Yeah. Okay. All right. Whoa. Hey, too fast. Taking it back. Okay. Oh, I'm sorry. I'm so not ready. All right. We're live. If it's your first conference and you don't really know who the Colorado Health Institute is, we are a nonprofit public health institute. We strengthen communities and systems with trusted analysis and collaborative solutions to improve health. And we've been doing that for over 20 years, and it is an honor and a privilege to be able to work with all of you. We do this work in 3 ways. Now we're going to make this work. We answer critical questions, make sense of complex issues, and support others to reach actionable solutions. And this is really the backdrop for our conversation and our conference for today. So let's dig in and I'll tell you what I mean by that. So we are all here, I suspect, because we have questions. We don't know what the change in administration for next year is going to mean for health, for public health, for the programs and the services that we care so much about. And after, in just 10 minutes, according to Rachel, my colleague, Managing Director of Research, Evaluation, and Convening, Emily Johnson, is going to take the stage, and she's going to answer those questions for all of us, as best as she can, with the information that she has. But we know there's a lot of wisdom in this room, too, and so that's part of the deal. It's a conversation. We make sense of complex issues. And the electorate feels more complex than ever. After our break, my colleague and CHI's new Managing Director of Partnerships and Development, Karam Ahmad, is going to be joined on the stage with 3 veteran, seasoned, exceptional Colorado journalists who will help decode some of what they saw in the 2024 elections, but more importantly, help all of us who are really working to advance the public's health and think about how to engage with our communities. They're going to help us and share their experiences trying to do that as journalists. And that communication, building that trust, figuring out how to have those conversations feels more important than ever. Oh, hey, and there they all are. So you'll see them in about an hour. And lastly, we support others to reach actionable solutions. And all of you, or many of you, do your work in the state capitol. If you don't do your work there, you're directly impacted by what's happening in the Capitol. And we will be joined to wrap out our day by our Director of Communications and legislative expert, Joe Hannell, who will be giving his annual legislative preview. And let us know what to expect. He'll kind of paint the stage for us in terms of what we're all going into at the State House and what are some of the things that we need to be ready for and ready to respond to and move forward in the year ahead. So this is our day for today. Before we go forward and jump into it, I want to kind of ground us in where we are, and in particular, where we were a year ago at last year's Hot Issues in Health. So I realize that many of you, it's your first time, so you weren't here last year. If you were, this slide might look familiar. We released some early results of the 2023 Colorado Health Access Survey. It was our first survey post-pandemic, and it represented the first real comprehensive look at how Coloradans were faring coming out of the pandemic on health and social issues. And we called our presentation Peaks and Valleys. We talked about that we anticipated, and perhaps correctly, that we were still in the low valley, that valley of a low uninsured rate, because of the timing of the survey and where we were as a state for the unwinding of the public health emergency. At the same time, we also saw some tremendous peaks, and not tremendous in terms of good news, but we saw highest rates of food and housing insecurity, of poor mental health across a variety of populations. We learned that more than half of Coloradans didn't feel that their communities were prepared to respond to a climate disaster. We also, at last year's conference, referred to the 2024 elections as being unprecedented and unpredictable. I think we got it, but we probably could have called the whole year, I should stay closer. We probably could have called the whole year of 2024 unpredictable. I'm sorry, unprecedented. Well, maybe both, but unprecedented feels a little more accurate because in the last year, we've already heard the word headwinds once already. This is going to be a theme. 2024 saw us on the other side of a $10 billion public investment in our state and local governments and services. $10 billion had been allocated and spent in 2024, and there was no backfill to these one-time funds. We also saw over 1 million Coloradans who were previously continuously enrolled in Medicaid have their eligibility be redetermined as part of that public health unwinding. And we know that Coloradans have experienced changes in their coverage. We also heard from many of our providers, but most specifically our safety net and our rural providers, that they were facing unprecedented revenue challenges that have resulted in layoffs and service reductions, which have direct impacts on all of us. And these are just some of the headwinds of 2024. And I bet if y'all took a minute, you could identify probably several more. And so this is where we are launching. This is where we are today. And then we're moving into 2025. Okay, it's a lot. And I'm curious, and I think all of us are curious, what is on your mind? What are you thinking about as you're thinking ahead to 2025? What are you worried about? What are you excited about? What is a priority for you? What is top of mind for you? And this is not a rhetorical question. I actually want to know this. So hang on here. Okay, if you're in the room, sit tight for 1 second, because what we're going to do is I'm going to ask our online audience I'm going to try this again. I'm really going to hope it's going to work. You don't have to do Menti if you're in the room. You're all good. Okay. If you're online, please respond to this question. If you're in the room, huddle up with like 1 or 2 people who are around you and just take 30 seconds. Be like, what's top of mind for you? What are you thinking about as you're entering into 2025? Go. Hi, John. I'll talk to you. Or do you want to, well, why don't you talk to some guests here? Do you know any of these? Why don't you even talk to Emily? Thinking about getting some water. Okay, just a couple more seconds. Hopefully you've had your discussions. All right. Okay, everybody. I know this is the wild card when you ask people to start talking to each other. If you can hear my voice, raise your hand. That works. Excellent. Jane. Okay. All right. Thank you. I'm going to want to ask 1 person or 2 people in the room to share what they shared, but let's take a look. We have 67 responses from our online participants here. Public benefits, TABOR, budget shortfalls, reproductive rights. Curious, show of hands, any of these? Did anyone in the room mention any of these things? Yep. Okay. I don't know how to make it scroll, but we'll have this available for others. Someone else want to shout something out that you talked about? What's top of mind? Maybe that's not up here. Catherine.
Attack on the United Healthcare CEO yesterday was really unsettling.
Yeah.
The attack on the United Healthcare CEO yesterday and lost of life.
Sorry to make you have to say this 3 times because she is saying that the attack on the United Healthcare CEO is very unsettling for all of us. Yeah. Ma'am, back. Immigration, thank you. Anybody else? Way, back. Disability rights, thank you. Yes. Impacts on children, thank you. Yeah, all these and more. Thank you for, okay. All right. Yeah, here we go. Okay. So that's what we're headed into. And these are just some of the things that's on our minds. I want to offer us 3 things to hold on to as we begin our day. Focus on what works. Find agreement at 10 feet, not just 10,000 feet, and forge ahead. So focusing on what works. Not surprised that Dean Bradley mentioned this, but I invite us all to double down on our commitment to evidence and data in 2025. And I appreciate I have a bias because that's what we do at CHI, but I think if you come to Hot Issues in Health, you care about that too. And let's prioritize that in our choices and our actions as we move into the new year. And we can do that in 2 ways. First, we can invest in evidence-based programs and programs that are demonstrating the results that we are looking for. But connected to that is collecting the data that we need, both to let us know what programs are working, but more importantly, to understand what is happening at a population level and help us understand differences within communities and across populations. And especially as we all have questions about what data collection and what data will be available at the federal level as we move into the next administration, state level data are critical to inform our work. So let's invest in them. But if we're going to do that, we have to be willing to let go of what's not working. And it's so easy to put that on a slide. And sometimes it is easy to do that because it's really clear. But more often than not, stopping something involves painful choices and hard decisions. And it usually involves people who we really care about and programs that we really care about as well too. But let's find agreement at 10 feet and not just 10,000 feet. And here's what I mean. So if I asked you all to get back together in your same groups, which I'm not, but if I did, and I said, go ahead and come up with a shared goal statement of something you all believe in as it relates to health insurance and mental health and environment, I suspect it would be a very quick activity because I think it would take y'all about 30 seconds to come back and say things like health insurance should cost less and we want our young people to put their phones down and improve their mental health and everyone has a right to clean air and clean water. Then if I said, go ahead and go back into those same groups and come up with solutions and strategies to implement those 3 goals, we might be here for a longer time. Because the what is easy, but the how is hard. Because once we start talking about solutions and actions, your revenue is my cost savings. And my regulation is your red tape. And your program is not necessarily meeting my needs. And so we get stuck in the how, and that's where we start to lose trust with each other. And if we don't have that trust, we can't get to the solutions. And we will be entering a year where we might be challenged on the what. So let's find ways to come to consensus on some hows. Because lastly, we have to forge ahead because in a year, maybe a little less than a year, we will all come together and look at the results of the 2025 Colorado Health Access Survey. And we will know for certain who is and is not covered by health insurance and why. And we will know how different populations are doing on mental health. And we will know if our communities will know what's happened with access to care and where we have communities that are struggling with their readiness around responding to climate change and climate disasters. And whether we come together and look at peaks or look at valleys has a lot to do with what we do in the next year. So I invite us to focus on what works and find some agreement at that 10-foot level and build that trust with each other so that we can build that positive momentum and achieve the outcomes that we are looking for. Because the community that is here and that is joining us online is not one to shy away from a challenge. And you all have taken on really hard things in the last 5 years, really hard things. But if we focus on what works, and again, we find some agreement, I know that we can achieve the changes that we are looking for. And our job at CHI is to make sure that all of you have the data and the information that you need to be successful. So for today, please dig into the content, please ask questions, please meet someone who maybe you have never met before, hang out after and have some lunch because it's always fun to chat with everybody, and leave today ready to forge ahead. So again, welcome to the 2024 Hot Issues in Health Conference, and I am really excited to turn the floor over to my colleague, Emily. Thank you.
Let's see if I can get this to work. Full disclosure, I had this cute outfit on this morning and my daughter spat up a bit on it. So I had an outfit change. So my mic is in a slightly different spot. This seems to be working. Okay. Hi. Good morning, everybody. I'm so happy to welcome you all to the Hot Issues in Health Conference. We're closing out our first part of this morning, leaning into that pillar of our strategic plan that Sarah shared around answering critical questions at a federal level. And I have to admit, this is a place where there are a lot of questions right now. I probably won't be answering all of them, but I do at least think that that there are a lot of questions that we can ask right now. And so while I don't have a lot of solid answers to share about the incoming administration today, we are teasing out what those questions are that we should be asking and where we should really have our attention focused. I see a lot of familiar faces in the room, and I saw a lot of you all at registration, but for those who don't know me, my name is Emily Johnson, and I am CHI's Managing Director of Research, Evaluation, and Convening. I have been with CHI since 2015, so through 3 presidencies going into the 4th. And I really work, I do a lot of our work on policy analysis, but I've been in that field at the national level for longer. So I would like to see, just by a show of hands, who has been in the fields of health or health policy or research since before the ACA was passed? Yeah, cool. Me too. How about people who have joined this field a little bit more recently? I see a few shy hands up there. Okay, great. So for those of you who are a little newer to this world, buckle up. Because while part of me kind of thought like, oh, okay, I've been through this before, we've seen ebbs and flows, I think that actually having been in this field for a while really makes me appreciate how large some of these changes that we're talking about can be. They really truly can be seismic shifts, because I remember 2013 and I remember 2015 and how different it looked when we suddenly had an uninsured rate that was cut in half in Colorado. So we're going to be talking about a lot of those different sort of seismic shifts today. And if there are only 3 things that we're hoping you come away with today, they are these. And I want to preface this all by saying, as Sarah noted, we all kind of have our phones out all the time. There might be this sort of fatigue talking about RFK Jr. and talking about Dr. Oz. I'm hoping we can really distill all of those goings on into 3 things about how we think about these changes regarding Colorado, our health, and our budget. The first major theme is that when we think about Donald Trump's health agency and department nominees, it's really notable the degree to which these are individuals that question expert consensus on a lot of health policies. And I think that's true of a lot of Americans right now. We are seeing a lot of polls showing people have increasing suspicion in the traditional institutions in the United States. But what I thought was curious about this, and actually initially I had this takeaway listed as, I think, traditional expertise. But as we're going to go through looking at a lot of the heads, nominees to head different agencies and departments, you'll see a lot of MDs after the names of these guys, and guys, they all are. So these are people who have, there are people who have a lot of those traditional credentials, but they're really just coming at this from a place that is not itself very traditional. Second, it sounds like a lot of the policy decisions that we're going to see are probably driven more by budget than they are by ideology. So overturning the Affordable Care Act wasn't a major GOP platform in 2024, the same way it was in 2016 and even 2020. But what we have seen is this theme of limiting spending within the state government. There's even this Department of Governmental Efficiency that we're seeing come up. And so this is really a major theme, and that's, I think, what we're going to see driving this. It's important to remember that we still have a Congress that controls the budget. So a lot of the circles around the administration aren't in total control here, and we'll look at that in a bit. And then finally, when you combine these two conditions, we are likely on the cusp of some pretty seismic shifts when it comes to health policy at the federal and at the state and even at the local level. There is so much to think about here. Dean Bradley and I were kind of talking about this before. There's almost like this analysis paralysis, or I forget exactly how you phrased it, Dean, but like there is this sort of like, it feels overwhelming and you have to figure out where you're going to focus. And so what I'm hoping to do today is to perhaps take a first cut at compartmentalizing some of these major issues and major changes that we're thinking we're going to see as we lead into the next federal administration. So we'll take a look at some of those possible shifts in the next half hour or so. So let's again remember the stage, as Sarah put it, the stage that has currently been set for us, or the place that we are currently working from. We are heading into a trifecta, a Republican trifecta at the federal level. In other words, control of the Senate, the House, and the executive branch. And trifectas can be pretty powerful, right? And these margins are not minimal, right? There's some pretty strong margins there. And so, getting legislation passed might sometimes face some opposition, but these are pretty strong margins. For some context, like some big things that have happened when there have been trifectas before include the Affordable Care Act. So really big things can happen in these spaces. And I know that people probably have different feelings about that depending on where you're at. And so like I said, health policy was not a major priority for the Trump campaign in 2024. And I think that means it's unlikely to be a priority for Trump as a president, not just as a candidate. Even with the trifecta in the executive and legislative branches, overturning the Affordable Care Act faces an uphill battle. I think there are two headlines that I've pulled out that really kind of frame the conversation and where we are today. The first is Trump's comments about the ACA during the presidential debate. He was asked by one of the moderators around whether he would continue trying to pursue new federal health policy legislation. And he kind of had this infamous quote around having concepts of a plan, which indicates he's probably not thinking about a replacement bill like the one that we saw in 2017. Does anybody remember what that 2017 replacement bill was called, the famous John McCain bill? Who remembers that? You shout it out. I think I heard AHCA, yes, the American Health Care Act. So this dominated a lot of our lives for a while in 2017. And it's kind of hard to remember the name of that bill. I actually had to double check myself when I was putting together this presentation, because it seems like that debate has started to lie pretty fallow. And so while, again, a lot of changes are subject to approval, I think a lot of the power that we are going to see probably reside in the people that are heading the agencies that are going to touch on health policy. And this is where the second headline comes in. Trump's famous statement that he will let RFK Jr., quote, go wild on health. So I think this is where we're really going to be watching, and well, spoiler alert, for the next half hour, what we're going to be talking about is really this locus of control within agency and departmental heads, rather than a potential new ACA replacement. So let's start with the biggest of those agencies and department, which is the United States Department of Health and Human Services. The potential head of HHS is, of course, Robert F. Kennedy Jr. And I am going to refer to Trump nominees throughout. I, of course, want to caveat this all here, like no one has been confirmed. These are also sort of nominees right now. We have already seen in some other agencies, nominees have already kind of started to turn over. And I also want to reiterate that even if these are the eventual appointments of these different agencies and heads, their plans aren't written in stone. We don't yet know exactly what they will do, but we are kind of looking at them for leading indicators of what we think is going to happen. So RFK Jr., what we know is that he has spent much of his career as an environmental lawyer. He is a former presidential candidate, and I think I was going to say during earlier in this, like I think it was only 6 months ago that he was. It was actually less than 4 months ago. Things have changed quickly. So he was a former presidential candidate during this election. He is very famously an anti-vaccine activist. He heads up a nonprofit called Children's Health Defense that is looking at trying to reduce vaccine uptake really across the world. He's also pretty famously a medical conspiracy theorist. He has talked about beliefs connecting Wi-Fi radiation to cancer. He has talked about beliefs that say HIV is actually not the cause of AIDS. So he has sort of espoused a lot of these rather fringe beliefs in the past. And he also has a strong focus on alternative medicine, which includes things like psychedelics, as well as wellness, which includes things like the food that we eat. Health and Human Services is a collection of agencies and offices. Here we've listed the public health and human services agencies that fall under its umbrella. There are 13 subordinate agencies. I've also included the Office of the U.S. Surgeon General up on this list. So if you're counting, you might see 14 points, just because of the influence and power that Surgeon General can wield. All told, HHS controls an annual budget of well over $2 trillion, which makes it, by kind of a wide margin, the largest federal agency. Does anyone have an estimate of how many cents of every federal dollar is spent somewhere within this multiverse? Shout it out. 40? 60? Okay, I thought people would come in lower. It's 25, but that's still a lot. That's still a lot of spending that happens somewhere in here out of every single federal dollar. And the agency employs 80,000 people across the globe. So there is a ton of complexity in this department. And when I'm talking about complexity here, it's not just in terms of the very complex subject matters that these different agencies deal with. It's also just administratively, it is wildly complex. It is international. It's a large, complex organism. So each of these HHS agencies obviously plays a really important role. But today we want to focus on the potential impacts and changes across 4 offices, again, just for the sake of focusing. We'll be looking at the National Institutes of Health, the Food and Drug Administration, the Centers for Disease Control and Prevention, and the Centers for Medicare and Medicaid Services. The picks to lead these offices are the movements that I'm guessing most people in this room are probably following the most closely. But before we turn to these 4, I don't want to ignore the other 9. So can I ask you to raise your hand if your focus is on one of these other 9 offices or agencies right now? Okay, great. What are some of the places that you guys are looking at? AHRQ, I knew there would be someone saying AHRQ. Yeah, Sarah called it. Anybody else? SAMHSA, yeah, a lot of focus on SAMHSA right now. So actually, could you just raise your hands again if you raised them just now? So I would encourage you all to talk to these people during the break to hear a little bit more about some of the areas that we're not really going to be looking at today, because these are all hugely important agencies. But turning our attention to the 4, we're going to start with a deeper dive on the National Institutes of Health. The NIH is, of course, the primary agency for funding medical research in the country. It has a budget of about $50 billion, employs 19,000 people, and over $500 million of that annually comes into Colorado. I think it's also important, though, to remember that the National Institutes of Health is the National Institutes, plural, of health. It's actually a collection, a network of 27 institutes and centers across the United States, and each of those already have their own dedicated biomedical disciplines that they're looking on. So a lot of the changes that might have been sort of talked about in terms of direction of the HHS in this context can't necessarily happen overnight. If you are an institute that is focused on cancer research, that's hard to not be researching cancer overnight. But what can potentially change with some congressional approval is the funding. So to kind of underscore again how this connects to Colorado, again, $500 million on an average year has actually been more the past few years during COVID. The grantees that you know and love include CU, the school where we are right now, Colorado State University, National Jewish Health, and a lot more across the state. So really, if you are doing research in the biomedical field, you're probably kind of connected to the NIH in some way. If there is a spectrum of orthodoxy by which we could, or on which we could place, I guess, Trump's presumptive nominees to head a lot of the agencies under HHS, Jay Bhattacharya is probably one of sort of the more conventional picks. He has a medical degree, although he didn't practice as a doctor, he didn't complete residency, because he has a PhD in economics and is a professor of health policy research at Stanford. The major controversies he's seen in the past were really around COVID-19 lockdown and quarantine restrictions. He advocated for lifting a lot of those in favor of herd immunity. And there was a semi-famous open letter that he signed during the lockdowns. I love audience participation. Anybody remember it? The Great Barrington Declaration. Yeah. So, yeah. John Douglas, of course. Yes, the Great Barrington Declaration. He was a signer to the Great Barrington Declaration. So he has had a lot of these kind of controversial opinions. So he's not a politically neutral figure, but he has called vaccines successful in the past. And a lot of his inroads with RFK Jr. seem to be mostly around wanting to fund more innovative techniques in research. He hasn't been explicit about what those innovative techniques might be, but his interests indicate things like cancer spotting AI or wearable technologies when it comes to how we look at research. And as I think I mentioned earlier, we are going to look at each one of these departments and try to really distill it to one seismic shift that we are looking out for. Within the NIH, the most focused proposal that we currently have to work with is RFK Jr.'s statement in a Wall Street Journal op-ed in, I believe, September, saying that he would plan to, or that he believes half of the National Institutes for Health budgets should be spent on preventive, alternative, and holistic medicines. Depending on exactly what Dr. Bhattacharya means by innovative techniques, this is probably not at odds with RFK Jr.'s priorities there. Next up, the FDA. By a show of hands, who fed a pet this morning? Okay, keep your hands up. This is going to be rolling. Who gave a baby formula this morning? Keep them up if you've raised them at all. Yeah. Who's wearing sunscreen? What about makeup or perfume? Okay, who ate food or used soap today? Gonna kind of assume we've got the whole room there. Great, so that means that your life has been impacted already today by the United States Food and Drug Administration. The FDA is, of course, tasked with ensuring the safety, efficacy, and security of most food, drugs, cosmetics, and more. It has a $7 billion budget and 18,000 employees. It does not typically distribute money to states, although there are exceptions to this because there are some pilot programs that have done this. And still, though, regardless, by a show of hands that we just saw today, the FDA clearly does impact all of us in our daily lives. Tapped by Trump to lead this agency is Marty Makary. I do want to kind of note here, because I think this is an interesting fact, and I'm not entirely sure what to do with it. There were 5 FDA commissioners under the first Trump administration. That is not typical. So this is a role that saw a lot of turnover in the first Trump administration. And when I say I don't know what to do with that, it's because I'm not quite sure why that was, but I do think it felt notable and worth bringing up here. But this is currently who we're seeing tapped, is Marty Makary. He is a surgical oncologist. He worked closely with the first Trump administration on surprise billing, and he has authored a number of books on healthcare costs, and has a lot of visibility for his writing and research around transparency, which is why it's probably no surprise that he did this work on surprise billing. He's a frequent guest on Fox News, and he was a very vocal critic of the public health response to COVID-19. And he often speaks on Fox and in other settings, such as roundtables around the importance of food, and emphasizes concerns over chronic rather than infectious diseases. You might be noticing a theme there. In terms of the seismic shift that we're looking at with the FDA, I think it's kind of this paradox of increased oversight in some areas and decreased oversight in others. So we might be seeing less oversight and regulation of things such as psychedelics, ivermectin, and raw milk. And this is actually kind of a famous quote now. RFK has referred to the FDA in the past as waging a war against public health by suppressing raw milk. Where we might be seeing increased oversight is on things such as pesticides, processed foods, and vaccines. And while increased oversight can, on first blush, feel like it's always a good thing, I think how this will play out is really going to depend on what types of additional studies we're thinking about when we think about increased oversight, and what the types of evidence that are being weighed there are. Next in the lineup, Centers for Disease Control and Prevention. The CDC's mission is to protect Americans from health threats, prevent disease, and promote wellness. Its budget is around $12 billion, has 12,000 employees, many of whom are contract employees, and $250 million of this every year funnels to Colorado. The types of programs that you may know and love that are CDC funded include, the types of local programs, I should say, include our Emerging Infections Program, Colorado Healthy Schools Program, lead poisoning prevention. Is there anyone else who's currently working on CDC funded programs? And what are they? You probably are, or someone probably is, and it's okay if you're feeling shy today. I assume a lot of people in this room are probably working in a program like this. A lot of them are run through local public health agencies or the Colorado Department of Public Health and Environment. So please throw to the chat if you're online, or if you think of it later, let me know during the break what kinds of programs that you're working on, since a lot of the kind of public health space happens with CDC funding. Trump has selected Dave Weldon, who is a former Republican congressman, to lead the CDC. Weldon is a bit of a darling of the vaccine autism controversy movement, although when looking at things he had actually said in this space, truly the furthest it seems to have gone is in him saying that he thinks more studies are needed when it comes to the potential connections between vaccine ingredients and autism in kids, which is still a widely debunked theory, but I will say he has made public statement that his own 2 children are vaccinated. But he is still very much an RFK style pick. He has tried in the past during his political career to remove vaccine oversight from CDC and transfer it to an independent agency. So right now, the CDC director has autonomy to accept or to reject the vaccine recommendations that come out of the Advisory Committee on Immunization Practices, which is a group of pediatricians and other researchers. So whether or not he feels that this should still come out of the CDC might end up depending on whether he is leading the CDC. So it might just not feel like he has the same urgency behind that if the CDC director is him. So I'm not quite sure how much that will apply to a situation where he's actually at the head. And the big news from the CDC is likely to be a shift away from infectious disease and to chronic disease. There have been many, many signals, and we've mentioned a few in this presentation already, that this is the direction this administration wants to go. And for some of us in public health, it might be like, oh, great, like chronic disease is getting its due. You know, we have looked at chronic disease. We know it's the leading cause of death for Americans. So it kind of might feel like, oh, do we prefer this shift? But I think it's important to remember that a lot of infectious disease work is still preventative. So think about vaccines for children, that program, or that would live under this infectious disease category. And I would also note that when we're thinking about chronic disease and chronic disease prevention, a lot of really important things are probably happening in other places in the Trump administration that could work against this. So for example, Brooke Rollins is the current president and CEO of the America First Policy Institute. She will probably be up for Secretary of Agriculture, where if the plans that have been outlined by the America First Policy Institute carry into her policymaking, we're likely seeing some pretty major cuts to food programs like SNAP, which is the food stamps program. And so how does that work with this priority of reducing chronic disease prevention and reducing chronic disease and investing in prevention? Right now, roughly a third of funding in the CDC budget goes to infectious disease, and a little more than a third, well, a little less than a third to chronic disease. And then there's like a little bit more than a third that kind of goes to this other category, which includes things like bioterrorism and additional supports for public health. So in this sort of large bucket, you could imagine that some of it likely goes to chronic, things that we might characterize as chronic disease. Some of it goes to things that we might characterize as infectious disease. But for the money that fits into one of these two categories, it's kind of like 50, or I should say pretty close right now, how much the CDC spends on chronic illness and how much the CDC spends on infectious disease. The question here is, if we want to invest more in chronic disease, less in infectious disease, what's the right balance here? And then, of course, the question behind that question, I saw somebody mention that what they were looking at in 2025, and they listed bird flu. If avian flu, if H5N1 becomes an outbreak with its higher fatality rate than COVID-19, and we have invested less in infectious diseases and haven't ramped up vaccine production ahead of time, et cetera, like kind of who's left holding the bag, for lack of a better term? Like, is it local hospitals? Is it local public health? What does that outbreak potentially look like? Last but not least, let's take a look at CMS. The Centers for Medicare and Medicaid Services is the agency that oversees federal health programs, including Medicare, which is the federal public health insurance program for older adults, as well as some people with disabilities and end-stage renal disease. Medicare Advantage, which is the public-private partnership version of that. Medicaid, in Colorado, that's called Health First Colorado. I had the weirdest, Rick Perry moment there. Sorry, Health First Colorado. We work with them all the time. They obviously cover a lot of low-income children and adults, as well as people with disabilities, as well as older adults as well. A lot of people are on Medicaid and Medicare, as well as the Child Health Insurance Program, which is in Colorado called CHIP Plus. It has the largest budget, I should say, of any of the HHS agencies, which makes it the largest agency in the largest department of the federal government. It's $1.5 trillion. It's so much money, but it is important to remember most of that is what we would kind of consider pass-through money. It's money that ends up going to providers and clinics to pay for these health services under these programs. These are entitlement programs, and they're kind of part of our social fabric. So right now, the way these work is if you qualify to be enrolled in one of these programs, the federal government says that you get it. CMS has fewer than 7,000 employees because a lot of the work that CMS does happens through third parties or through at the state level, through probably a lot of people in this room. And almost $10 billion in our state's budget comes from CMS. Joe will break that down in a little more detail and put it into context later. If we're talking about a spectrum of orthodoxy for the Trump health nominees, and Jay Bhattacharya was on one end, I think Dr. Oz, we could say, is probably on the other. He is a cardiothoracic surgeon and a professor emeritus of cardiothoracic surgery. He is most famously a television personality. He doesn't have a lot of the kind of administrative experience of leading a $1.5 trillion agency. He has a strong interest in alternative medicine and faith healing, which has been quite public, and this has included selenium supplements for cancer prevention, homeopathic cures, diet pills, detoxes, cleanses, as well as promoting a lot of faith healing and faith healers on his show or on segments of shows he was on. He was a former Senate candidate, if you'll recall, against John Fetterman in Pennsylvania just a couple of years ago. And I think it's interesting, given the position he's looking at, that during that candidacy, he had this Medicare Advantage for all platforms, so a broader privatized Medicare Advantage option that he was really running on. Notably, those pages are no longer up on the site. So that probably signals this maybe is not a direction he's going, but this was one of his campaign platforms during his Senate race. So let's do a quick reminder of Medicaid and who it covers, because that's really, I think, going to be the focus when we're looking at CMS, at least here today. As I said, Medicaid covers children. It also covers a lot of low-income adults without dependent children, many, many older adults, and many people with disabilities in the state. So what we're probably looking at in terms of a seismic shift for Medicaid is really just funding cuts. Like, that has been a drumbeat frequently throughout this administration and through the nominees. And there's sort of a spectrum of funding cuts we might be looking at. On one end, sort of a little bit easier to do, maybe less sort of radically different than what we're currently seeing, but still extremely impactful, is a lowering of the federal match. And I'll look at what that means in just a second. On the other end, potentially a bigger cut, a bigger change to how Medicaid has historically been administered as an entitlement program, is moving to block grants. So lowering the federal match, this is what that would look like. Right now, today in Colorado, this varies by population for all the policy wonks in the room, but on average, for every dollar that we spend on Medicaid in the state of Colorado, 65 cents of that dollar is given to us by the federal government. What we could be looking at under a lower Medicaid rate is more of like a 50-50 match. So, if we kept our Medicaid benefits at the level they currently were, that difference between the 35 cents per dollar we're currently paying and the 50 cents we'd pay here would be hitting our state budget. So on the other end of the spectrum, and the reason I put it on the other end of the spectrum wasn't just because of the potential impacts in spending, but also because of how fundamentally it can change things, is this idea of block grants. And so before we get into that, I think it would be helpful again to review our current system for Medicaid and how that works. Today, Colorado administers Medicaid. We spend state money on these programs. We also get federal matching funds when we do that. And that match, it's visualized as 50-50 here, I know, I just said it wasn't, but that match applies to every single dollar that Colorado spends. So we spend an additional dollar and we get an additional federal dollar. And a match of this sort continues to apply. Proponents of this system say that it ensures spending is sufficient to cover all populations covered by Medicaid, whether there's a sudden increased need because of an economic recession or a natural disaster or an outbreak. The concern among some fiscal conservatives is that this could incentivize the state to overspend, since for every dollar the state is spending, they're really kind of only risking 50 cents of the state's own money. And likewise, for every dollar the state saves on Medicaid, they're really only saving 50 cents. So a common conservative proposal that we see is moving to a block grant. Under a block grant, you get a set amount of federal money. And then no matter what happens with enrollment, if it shrinks or if it increases, that federal money stays the same, and it's largely up to states how to administer it. Every year, the changes would probably only be something like growing that federal pot due to related to inflation or population growth, but we would have to wait for a final bill for specifics. There are some concerns that this could incentivize states to limit enrollment or to limit benefits if the amount of money there is set. We don't yet know exactly how the amount of a block grant would be determined, and the extent to which a Medicaid block grant comes with certain requirements or restrictions is still unknown. We can guess what we would want Donald Trump or RFK Jr. or Dr. Oz to see, but changes to Medicaid do still need to go through federal legislature. And so even with the trifecta, we might see some of those more moderate Republicans or more moderate conservatives in the Senate or House really push for a requirement like Medicaid still has to cover all children at a certain poverty level or something like that. So we don't quite know what that would look like, but this would still be a major shift, taking something that has historically been an entitlement program. If you qualify, you get it, and placing it pretty squarely into a category of not being an entitlement program anymore. The most famous, I think, corollary we have for this is changes to temporary assistance for needy families or welfare in the late 90s, I think it was, when we switched from having it be an entitlement program to being a block grant. So if you want to look at that, what that might look like, there are some historical lessons there. I also want to just recognize right here that we listed what we were kind of considering the 4 major seismic shifts in these 4 agencies. I'm sure a lot of people in this room are tracking closely on your own. So please connect over the break, talk about what you're focused on. Please come up to me and tell me what you're really focused on as well, because it's going to be an interesting couple of years. So again, uncertainty really does abound, but these are a few things we think you should keep your eyes on. First, again, we have a number of nominees that question expert consensus when it comes to health, healthcare, health policy, and medicine. We think that the budget restrictions that have been talked about a lot are probably going to be driving most of this policy rather than a wholesale replacement of the ACA. And again, combined, these can create some seismic shifts. I think that it's important to also note at the end of this presentation that this is really what Americans voted for, right? Like we voted for some of these shifts to happen. And so I think it's going to be really interesting, especially after the break. My colleague Kara Mama will be talking to some journalists about how we receive information and think about information and how that's ever evolving. And so I think that I just want to put a plug in there. I'm really excited for that conversation. So with that, I will close out the first part of this morning. Just some housekeeping quickly. Our break is going to end promptly at 10:30 to begin that amazing journalist session.